So I'll start with Jamie's work because that got me really intrigued. I have a conflict of interest because I'm a general practitioner, so I could also be gaming the system in some kind of way. Perhaps not exactly with this problem because we don't have the incentives that you have for home visits. But what I find really interesting is that if we want some public accountability by the use of public resources, then we have to have independent people assessing whether we're gaming the system or not. And that was really interesting to watch your presentation. But what I was considering was that you found that there were more GPs who believed that they were traveling furthest than the ones that were thinking that they were traveling a shortest distance, and that was a very interesting result. I was very interested in knowing whether this would also happen in a system that didn't have the same financial incentive.
Thank you for your kind words. I also think it's an interesting project, but I'm also biased. Whether we'll see this in other contexts, I think what's interesting in this paper is we see that we have GPs have a financial incentive for them to round up their travel distances incorrectly. Whether we'll see that in other systems where there's no incentive to do so, maybe, but it doesn't. This wouldn't matter for the health payer because the health payer receives no cost for them being incorrect in the running up. Whereas in this paper we find that the cost of upcoding is greater after the fee rise.
Mm-hmm. And I agree that it has such an easy fix and that it seems just obvious to tackle it. But I'm concerned whether this is robust enough evidence to support that GPs are deliberately playing the system, and that's why I was interested in knowing whether this is some form of cognitive bias and would happen to another GP even though he or she didn't have this financial incentive, or whether there's evidence that actually there's some kind of bad behavior being done by general practitioners that needs to be tackled in a more systemic way.
Yeah, we tried to be. Our data isn't perfect. We had to measure the travel distances using Google Maps, but we were unable to use to account for levels of traffic or other sort of things that may change the route. But we've done some robustness checks by moving our definition of upcoding by 1 kilometer and 2 kilometers, and we find very similar results. So I think that it is slightly robust, but not perfect. Obviously not perfect. But yeah, there could be some sort of cognitive bias to it. But what's interesting is that we're trying to exploit this fee change. So we have some form of exogenous fee change, and we think that the cognitive bias shouldn't be changed from 17 to 18 after the fee change. So we're trying to control for the cognitive bias that could be there, and look at the fee change.
I've also watched with a keen interest to Anna's presentation because I really like the subject of treatment adherence, and you've shown a rather significant and clinically important result with a very simple intervention, which is switching patients from a loose to a fixed dose combination. I was very intrigued by your results because I was aware of similar studies in hypertension, and the magnitude of effects wasn't as big as the one that you showed. I tried to see whether there were randomized controlled trials assessing this issue because they would also be an important argument supporting your claim. And I did find some in type 2 diabetes mellitus, but they were very old. So I think there is a lot of opportunity in your study, especially now that we have so many other drugs that we had 10 years ago. So thank you for doing this. I guess that I was trained as an epidemiologist, so my concern with your work is whether the two groups were comparable at baseline. Okay, and I guess those are my major comments to your work. So very interesting. I would like to see why you found such a large effect compared to other studies, whether that's a reason for concern and an indicator of bias, or whether you have another plausible explanation for such a large difference.
Okay, thank you very much for your comment. First of all, technically, we really try to make sure that we isolate the effect of fixed dose versus loose dose combinations, and that we make the groups as comparable as possible. And therefore, yeah, we do kind of a two-step risk adjustment, where we first balance the individual based on observable characteristics that may be, for example, age or gender, or the comorbidities, the diagnosis they got, the medications they took. And then in the second stage, we do a difference in difference model, yeah, to really account also for the time invariant heterogeneity and really isolate the effect. So this was actually an aim of our study, yeah, to improve this causality issue compared to existing literature. Then, yeah, I agree that that the effect we observe is larger than the effect that's been observed in previous literature, which mainly comes from the US. And I think one reason for the difference in this, yeah, effect size is that there is no gold standard on how to measure adherence. And this, yeah, starts, or first of all, depends on the data you use. We use administrative data, which definitely differs from an assessment based on RCTs or even surveys. And even within administrative data, there are different approaches, and it's getting even more complex if you have to assess multiple medications such as loose dose combinations. So you could take a mean, or you could look at both substances separately. We in fact did a sensitivity analysis where we are playing a bit with the method we use, and we can see that we are coming closer to the result of the other studies. So I think this is one reason. But of course, there could also be, especially because the existing literature comes from the US, there could be differences in the underlying policies, in the underlying yeah, co-payment regulations. The European market is usually more regulated than the American pharmaceutical market, and the out-of-pocket spending is generally higher in the US, and that may also affect how the people adhere to medication. Yeah.
This was a really interesting work, and I guess that in Portugal, and those of us who are interested in primary care in Portugal are all interested to know whether this organization model actually brings benefit to the general population. So thank you for choosing this topic and trying to address it. I think I need some help from you to guide me through the results and through the methods, because I couldn't really get how to interpret the betas and how to interpret the other numbers, the deltas that you've presented. And that's because I'm not familiar with the methods. So I couldn't tell how clinically important or policy important were your results. Could you guide me through that?
Well, the idea here was to make something, well, we didn't have much until now covering all the country. What we had so far was a study, I believe, from the association, from the Group de Reforma, and they have used the average OSFP. So we tried to do something encompassing all the practices and adding some more elements to the comparison. So what we did here was the stochastic frontier model, which essentially counts, is a function on costs, and then it disentangles the error term, a term or efficiency, which we'd stipulate to have a certain distribution, and a term which is a random shock, which happens to all the practices, especially in this context, which is not correct session, but it's still a short time, so we had only a three-year period. So from the results, we were interested in knowing, first of all, whether there will be some difference, significant between OSF-A and OSF-B, and we're trying to account for differences in terms of production, in terms of costs, which account for production, and in terms of inefficiency. So we include, let me look at the presentation, so we include the betas, changing both the cost and changing the inefficiency. So we see is that in terms of these delta terms affecting inefficiency, we see that OSFP and OSF are associated with less inefficiency, which means distance to the stochastic frontier on cost. But what we were first of all interested in was knowing whether they do have different protection, they do have different costs. So if they do have different frontiers compared to the salaried models. And for that, we will then try to see if this was the same for all the sizes of practices. So jumping to the conclusions, what we saw was that indeed, OSF A and B are different from salaried models, but not the small-sized practices, not the practices with a lower scale. And these are not associated with lower costs for the same-level production. That's what the last graphic says.
The million-dollar question or the €1,000,000 question in Portugal would be how much of this variation that you find is actually due to the organization model or between differences among the served populations and the type of clinicians that are attending to these patients. For instance, when I had a look at the data, it seems that we have a very strong geographical variation of performance and the number of visits. With the northern part of Portugal having better production and better health outcomes than the other parts of the region. And it's very difficult to disentangle this from the organizational structure because they also have a lot more of this team-based models in the northern part of Portugal than they do have on the southern parts. So I guess that would be a very interesting challenge for you to try and understand what actually drives this change, both in production and the quality of the care that's being provided to these populations.
That's a very good question. The first question posed on how much variation is due to the model. This is something very interesting. Well, here we're just trying to see if indeed there is some difference. So when after adjusting for production, if there is a significant difference in cost related to the model, and how much, and explaining the mechanism will be some second step we'd like to go through. But it's a very, very interesting question we're following here.
So thank you so much for the three of you. All the works are really, really nice, and they have implications on policy making. So my discussion is mostly related to how your work can be used on policy making, on decision making. So first of all, I will start with Jamie. I believe that your work is very, very interesting. At my experience, not only on the issues that you are mentioning, but I will try also to open and would like also your comment on this, because your work mostly, and my interpretation is that there is some sort of a threshold where you pay the practitioners where they don't feel the need to game the system. So in that sense, and what I understand from it, and it can be lots of implications, for example, even to understand the behavior of doctors, for example, in low-income countries. I'm a consultant for WHO. I've been working in several countries in primary care reform. And actually what we see is that in most of the countries, there is informal payments, or this kind of under-the-table payments that mostly are, and we argue that they exist because the salaries are quite low. In that sense, I believe that if you increase, and I think you show that if you increase salaries, the need to game the system or to have unwanted behaviors are reduced. The other point is that actually, for example, in Portugal, we pay for, in the USF, in our Model B, in our more evolved model of pay for performance in primary care, we pay also for home visits, but we pay the lump sum for any home visit. So we don't consider the distance from care to the home. So actually, in that case, what we have seen in Portugal is that every month the doctor makes the full amount. There is some kind of cap in the number of visits, and they always fill the cap. So they don't over provide home visits, but they always stick to the maximum. So mostly my comment is also, how do you see your research applied to this kind of practitioner's behavior related to this idea where if we increase payments, if you increase salaries, if you are going to see a reduction on unwanted behaviors from the practitioners.
Thank you. Thank you for your comments. Thank you. Your comment about the low-income countries was especially interesting. I hadn't actually thought about that. It is important to note that the fee rise was very large. It was almost tripling of fees, going from around like 30 euros to like 90 euros per home visit. And we only see a decrease in upcoding of around 2%. So it is a very small negative, but it is negative, which is interesting. Whether that could be used as a way to used as a way in which we could reduce gaming and upcoding or other sort of sort out any sort of gaming behavior in other countries is I think more research is definitely required, probably in more of a lab-based setting, which is where we'll be able to like truly isolate the effect. Whereas ours is definitely observational. So there's some issues of measurement error. Regarding the second question about second comment about how it's done in Portugal, my third paper in the PhD actually seeks to estimate if after the fee increase they actually did more home visits after the fee increase, and we find that's not the case. So they don't do any more home visits after the fee rise, and they game a bit less. That's the effect of the policy was they game less and don't do more, but the gaming is less, but the cost to the taxpayer is greater. So the cost of gaming goes from like 80,000 euros prior to the fee increase and goes up to 300,000 euros after the fee increase. So it's a costly policy which reduces gaming, but also cost the taxpayer more money. So it's up for debate whether that's had an overall a net positive effect.
So what would be your recommendations for the payer in this case?
It's important to assess how much it costs the health department. This is about like 300,000 euros. I know that in Denmark they do actually measure your distance from your house to your place of work for tax reasons. So I'm sure that they have an algorithm that can do that within this setting as well. Whether that costs less or more than 300,000 euros a year is probably the deciding factor.
Anna Katarina, I also enjoyed very much your work. I think it's a different approach from what we have seen on treatment adherence. In my early ages, I work in HIV, and one of the issues for HIV, as you know, there are lots in the beginning of the century. The number of pills that the HIV patient needed to take was more than 20 per day. So actually, it improved a lot on the reduction of the number of pills, but also increased the cost of the medication. So there is always a discussion between this balance. In your study, you don't do, and you assume that you are not doing an economic evaluation of this fixed dose. But my question for you also is mostly related with the policy orientation. So mostly, and I will not discuss, as Bruno was saying, all the method that you use and all that, but mostly is also how do you see the results from your work being applied in real world, and also what kind of research do we need in the future to increase the robustness of your results?
Yeah, thank you very much for your kind words. It's true, like this study really only focuses on the health perspective, and here we are not focusing on the economic perspective, which is for a healthcare system very relevant too. And I have to look into this a bit deeper, but things like co-payments may play a role, for example, or the patent status. It's possible that maybe only like that the patent of the of the single substances is running out, but the combination drug is on patent, and then it's the question whether in the end it actually is worth it to prescribe the fixed dose combination if it costs that much more. This is something we are actually looking into that as well. Now in the second step, we are looking at the economic side. I think it's really important to get the full picture of the story. What I feel is that, of course, the medication adherence or the simplification in medication regimen is not the only way to address adherence. But I think it's a rather simple approach. It may also not be the one that has the biggest impact. I, for example, think that talking, like communication with the physician, taking time talking, education is very important as well, but it's way more difficult to implement. And I don't know, it really depends on the country, but often physicians are not paid for talking to their patients. And then it may be easier to prescribe a fixed dose combination instead of a loose dose combination. That may be just an easier approach, but it's definitely not the only one to address adherence. And the economic perspective definitely needs to be taken into account. Also, whether it depends on the system. Maybe sometimes you have to pay co-payments for your prescription, or you have to pay it for each medication that's on the prescription, and all these things will matter. Yeah.
Just a final question. During your desk research, did you or you found some data or meta-analysis that could also try to see the different impacts of treatment strategies? As you say, this is only one of the strategies. What kind of studies, or if you have found different interventions that could have a higher impact on treatment adherence?
No, I would have to look in this more deeply. That's true. So we very much focused on that research question, but yeah. Yeah, my feelings that, and yeah, from talking to experts, that communication really plays a really big role. Also, maybe fear of side effects, which can also be solved by communication and education, and definitely cost of medical treatment. I think it's a big issue, and it may or may not be solved by the fixed dose combinations. Yeah.
You know, maybe it's an idea to have this kind of meta-analysis that we could compare the different interventions.
Like really comparing how, to what degree each intervention could impact, and then
play a role.
Yeah, that would be really interesting. Yeah, like having a really big overview of possibilities for the policymakers. That's like our study really just focusing on one approach. That's true. Also, like with the digitalization, I think it opens so many possibilities with these smart pills, or with apps, reminders, and I think there are many new ways to address adherence.
Joan, I have seen it's a very interesting work. I have some conflict of interest because I was deeply involved on this implementation of this reform in Portugal. I have done some work on it also and try to evaluate with Julian Perelman also. We published actually a book on it with a study. My point is that the kind of your outcomes or the results that you achieve with this, and this is a broader belief discussion, what is the policy implication on your study? I think it's not clear at the end, and after you seeing your presentation, it's not clear, and I would like to hear from you mostly what is the policy implication from your study.
Yes, so apart from the $20 question that Bruna already posed, it is pretty much, we have these disparities across the country and these differences in different regions. I was just checking the model. Indeed, we control for that in the efficiency term. We also control for the IFS because we're also concerned with these differences in regions. But the idea here was, when advising on the conversion from the salaried model into this model, was trying to advise that it's not enough just to say we are changing this into a team-based model, to a WSF model. We should consider whether there are a couple of considerations in the new WSF, namely the size of the practice or the production size. And we're trying to conclude is that for these results that we have so far, those WSFs with a smaller scale, they are not different from those CSP in terms of cost, adjusting for production and for quality. And it's just what we're trying to bring to the front is that indeed there are some advantages coming from this model. We do not attempt to quantify how much it is so far, but we're trying to say, well, there are some considerations which need to be taken into consideration when converting in order to reap the advantage of a team-based model. Humbly, this is something we would like to conclude from this.
So you would say something that, for example, there is a minimum number of physicians for creating these kind of family health units. You should, for example, say that the ideal with a stochastic model could say that you should have at least 5 medical doctors, 5 nurses, and 2 clerical workers, something like that. Is that's the point of it? I believe that in that sense, the stochastic model should at least give you some idea what would be the ideal model of the conversion. I don't know if you got those results, but they are not presented, at least that's my perception.
Yeah, this cost function has this issue, which is they consider cost based on production scale, and the issue is that the number of physicians is highly correlated with number of visits. So we have to choose, we consider production, but we cannot include in the model the number of physicians itself. Okay. But you are right, we should think of straightforward measures which should be advised for. We're doing this in terms of percentile of number of visits, just because it is correlated with number of physicians. But you're right, for policymakers, this figure will be a more useful figure than simply saying the scale of production.
Mostly because of the costs are related, of course you're considering per visit costs, but mostly they are related with inputs, and the inputs mostly are the number of workers there. So I believe that sense I could be interested. I don't know in your costs also, and please let me know if you consider medicines costs. Yes. And the ancillary exams, everything. Okay.
Exactly. And great. The incentive, yeah. So it's the cost of the practice, including all that. We don't include something they have, for instance, in Denmark, which is the cost of the practice, like a square meter and so on. We don't have it for Portugal, but we include then inputs and physician induced costs, which is prescription and diagnostic tests.
Please allow me to start with an anecdote. Here in Portugal, physicians aren't paid for the distance they travel to the patient homes for house calls. But however, in type B family health units, they are paid 30 euros for each house call. This is meant to cover their travel expenses, but also to incentivize house calls. A few years ago, there was a decision by at least a couple of regional health administrations to forbid family physicians from performing house calls on patients who were residing in nursing homes. This decision seems to have been motivated by the fact that at least a few physicians were charging a lot of house calls in a single day because they went to the nursing homes and they visited a lot of patients in one go. This would probably mean they weren't really visiting all of them, weren't really taking care of all of them, but were charging for it. And so the decision was made to prevent every family physician from making house calls to nursing homes. It's interesting that today with COVID-19, family physicians are again being asked by the Ministry of Health to take care of their patients who reside in nursing homes. Regarding the findings of your study, I find it interesting that when the incentive increased, when payment rose, there weren't more physicians overbilling the health system for their travel expenses. I would hypothesize that there are a few family physicians that are willing to game the system in their favor and overcharge. And for them, you don't need that large of an incentive. While for the large majority of physicians, it's not a matter of the incentive, it's probably a matter of principle. They do not game the system, they do not feel it's right. So the issue here is, how do you punish those that try to game the system without preventing the other physicians from being adequately reimbursed for what they're spending?
So thank you very much for your comments. I think the response to how we ensure that that the minority of GPs do adhere to the rules is to how policymakers should react. It depends on the cost to the policymaker. If the cost is small, then there's little need for them to respond in a harsh way, just to highlight that there is issues of gaming within the Danish healthcare system. If it is very costly, you could implement systems which take out the GP's ability to choose billing codes. For example, the GP would put in the address of the patient he's going to attend, and he'll then get a fee associated with that visit that he is unable to implement the code himself. Denmark has this actually for income tax, because you receive less tax if you're further away from your place of work. So I think that the algorithm is already there within the Danish government. So whether to apply it to the healthcare system probably would be reasonably easy to achieve.
So 2 comments regarding your study. First, when you say there are no differences in complications, in diabetes complications, you need to consider that not only the follow-up period, but also that sitagliptin is a drug that has no evidence of reducing cardiovascular complications in type 2 diabetes. So it might not be no differences because there is no effect on adherence, but because the drug you chose is not proven to reduce diabetes complications. So I wouldn't throw away the possible effect of reducing complications with improved adherence. The other comment is that I wasn't quite clear on the slide where you presented subgroup analysis, and you mentioned that the subgroup with people without severe comorbidities seems to have benefited more than the subgroup with comorbidities. You presented that data, and you mentioned that it might be because in the subgroup of patients with severe comorbidities, patients might be focused on their other illnesses and might not benefit as much from the fixed combination. But you don't present us absolute data about adherence in those patients. So it might be that those patients have low adherence, and when you use a fixed combination, that it doesn't improve, or they already have high adherence and you have a ceiling effect that it doesn't matter if you use a fixed combination, they can't improve anymore. I would say that it's possible, as an alternative hypothesis, that for a patient with many comorbidities that already takes 6, 7, 8 drugs, one more drug doesn't make a lot of difference. Whereas for a patient with less comorbidities that only takes a couple of drugs, then one drug might make a difference in those cases. So that could be why you find that patients who take the least amount of drugs, or at least that you expect to take the least amount of drugs, benefit the most from using a fixed combination.
Okay, then thank you very much for your important comments. Regarding the complications, well, first of all, we chose sitagliptin because it was the most widely added substance amongst our group of insurance. And I'm wondering, so even if there was no evidence on the effect of this sitagliptin on cardiovascular outcomes, shouldn't we, at least or still be able to assess the effect coming from the other substance, namely metformin, and whether this differs if you take it as a separate pill or combined. And importantly, we do not claim that complications cannot be avoided with a better adherence. Thank you. We should definitely be clear with this, yeah, simply because we are not assessing the mechanism adherence here. We are really just comparing the different modes of medication administration and complications. Then to your second comment about the subgroup analysis, I totally agree that it would be interesting to look at the absolute numbers of adherence again and really differentiate if the healthier may benefit, simply benefit more because there was maybe more room to improve. And actually some studies even show that a lack of symptoms or feeling good can be a reason for poorer adherence. And lastly, regarding your interpretation, that if patients suffer from additional diseases and therefore potentially have to take more medication, like the extra gain of a fixed dose combination may just not be that fruitful. I think this is really interesting because it would actually be the opposite result to what we found when we looked at patients with polypharmacy disregarding their exact diagnosis. So thank you very much. We should definitely look into this once more. Thank you.
Regarding your study, I wonder what the mechanism would be for larger scale economies, because from what I understand from your methods, you're only considering average cost of healthcare professionals. And that would mean that the most efficient system would be one where you have one single physician taking care of a lot of patients. But of course that has a limit. Not only would patients have difficulty seeing their family physician, but also the physician might react by trying to be faster in patient visits. That could mean prescribing more drugs or prescribing more tests, which would make it more expensive for a single physician to have a larger amount of patients. Also, you could have burnout of physicians, which means they would need to be replaced, and that would also have costs. Concerning the differences between type A and type B family health units here in Portugal, you need to consider that family health units, professionals that are in type A family health units are there usually in a transition period to go through to type B family health units. So the amount of work that they produce usually is done because they see a future goal of achieving the financial incentives that are given to them in the type B family health units. So it's kind of a carrot and the stick situation. You have the carrot in front of the donkey and it keeps on moving, but if you take the carrot out, then the donkey won't move anymore. So I'm not sure if type A family health units would be that efficient if there was no type B family health units for them to aim their goals to try to achieve a future income when they are able to transition from type A to type B.
So the first question from Bruno was, what does it mean to increase scale? And he mentioned the idea of having more patients per physician would be could lead to some more costs given burnout, and there's some limit to the scale. So I would say that when I mentioned increasing scale, I mentioned the entire practice increasing, not simply increasing number of physicians of patients per physician. Though, as I said to Alexandre before, it is difficult to tackle them both because these values are correlated, and the cost function considers only the scale of protection and not the number of physicians in the practice. This is one. Then he gave advice, which was to consider that the type A practice is not a model per itself. There's not that there is some carrot stick issue behind. So it's highly related with type B practice. So I should never consider it separately when making conclusions. I should always consider them together because one leads to the other, and therefore we should see them as the first phase of one transition to the other, and never see them separately because they don't exist separately, which is a very nice advice.